Yeah. So I'll just talk about only the saying that this is the last one, and then I'll hand it over to you, and then you can start from there.
We are live. Anita, we are live.
We can start, Anita. Hello, everybody. Good afternoon and welcome to the last lecture in the series of Shri Rajni Turakhia's memorial series of lectures supported by Hoya. Today's lecture is the last among the 4 lecture series that were presented earlier. And to take it forward, I hand it over to Anita. Thank you.
So hello everyone, greetings and namaste. Welcome to the 4th and final lecture of Shri Rajni Turakhia Optometry Lecture Series in association with OCI and supported by Hoya. Before we begin today's lecture, let's hear a short video message from Mr. Yash Turakhia, grandson of late Shri Rajni Turakhia.
Good afternoon to one and all. I would like to take this opportunity to thank OCI and Hoya for this honor and memory of my beloved granddad. When I joined business back in 2019, I had worked alongside with him. Unfortunately, this did not last long as he departed for heavenly abode later that year. But in that short while, I had realized he was a deeply opinionated leader who would always put the interests of the industry first before his personal interests. He was a tremendous source of inspiration to several people within and outside the industry. There would never be a dull moment around him. His enthusiasm was infectious and would bring smiles and warmth instantly to people around him. Before I end, I would just like to emphasize on 3 strong points of his teachings that are very close to my heart, and I am sure these would come to us at some point of our lives. He used to mention, no matter what, never forget that only strong ethical business practices and value systems are the only recipe to long-lasting and sustaining success. Number 2, he taught us, no matter what, only quality will survive the test of times. And by quality, he meant in terms of product and service to your customers. And number 3, he always used to say, treat your employees like your extended family. No matter how exposed we are in today's world because of the internet and the ocean of information available at our fingertips, there are few core values only the learned people of the industry can teach you, and that only comes because of their years of experience. At last, I would like to thank the entire fraternity who have shown love and respect to him over the years. Thank you once again for giving me this opportunity to express myself on this occasion.
Thanks, Yash, for that beautiful message and sharing your learnings from your grandfather. So moving on, today's topic is on troubleshooting in progressive addition lens dispensing. This lecture follows the lecture on dispensing high-end pals, which was covered in the last webinar by optometrist Ajay Shinde. For those of you who missed it, please do access the past webinars which have been uploaded on the Optometry Council YouTube channel. All you need to do is go like and subscribe to Optometry Council channel and access all the past webinars. Today's webinar is being delivered by Dr. Vishwanathan. A brief about Dr. Vishwanathan, who's popular as Dr. Vishwa. Dr. Vishwanathan is a graduate from Elite School of Optometry and went on to complete his PhD from Anglia Ruskin, Cambridge, UK. He heads the Department of Optometry at Shankar Nethralaya since 2008 and has over 2 decades of experience in various areas in eye care. He is also an assistant professor at Elite School of Optometry since 2002, teaching undergraduate and postgraduate students of optometry. Joining him as panelist for today's session is optometrist Preeti Singh Rekhi, a graduate from Elite School of Optometry. He established his private practice in Chennai by the name of Spectrum Eye Care in 1991 and is practicing ever since. Alongside, he is Regional Asia Pacific Clinical Advisor for Special Olympics an honorary optometrist to the Spastic Society of India, as well as the Down Syndrome Federation of India. Welcome, Reiki. Joining him, we also have Ms. Reshma from Hoya in the panel discussion. Welcome all to today's session. Over to you, Dr. Vishwa.
Thank you, Anita, for that nice introduction. Let me try to share my screen. Is my screen visible, Anita? Are you able to hear me as well?
Yes, Vishwa.
Okay, thank you. So before I begin, it is a great pleasure to be part of this webinar. And when Lakshmi shared me that this is going to be a part of Shri Rajni Turakhia Memorial Lecture, I was doubly happy as I've had the opportunity to interact with Shri Rajni Bhai as well. So it is definitely a great honor for me. Thank you once again. And today it's going to be on the troubleshooting in progressive addition lenses. Okay, so I think as Anita said, it's a webinar series. And initially, Abhinav covered on some of the aspects of presbyopia and the need for presbyopic corrections, and also the options for presbyopic corrections were discussed. And Ajay actually did cover on some of the advanced design lenses and custom design lenses, and he did mention about some of the importance of markings in progressive addition lenses. Daman did talk about the evolution of progressive addition lenses. And before we move on, Paula, can we post the first question, please?
Sure, sir.
Logo வந்து temporal side வரும்.
Request all to keep your mics on mute, please. Thank you.
Vishwa sir, 70% of them have answered. Shall we close the poll?
Yeah, please. Thank you.
Sharing the results.
Okay, I think majority of them have answered correctly, so I'm not discussing the answer here. So let me move on to the next one. Ajay also mentioned about some of the importance of taking measurements for PALs, not only PALs, and for custom design PALs as well. If you look at the right side, there are some tools with which they are measuring this one. Let me show you. I don't know whether you are able to see my point. So this one is the distometer with which the vertex distance is being measured. This is the pantoscopic tilt, and this is the wrap angle. Ajay did mention how to record this and send it to the lab along with the regular measurements. So I'm not reiterating here. And Paula, can you post the second question, please?
Yes.
Okay.
What is the difference between the micro retina?
24. 24. Actually 24 the 34 la romba adu.
34, 38 எல்லாம் வராது இல்லைங்க சார். 24
24 தான்.
சப்மிட் கொடுக்குறது வந்து சப்மிட் கொடுக்கணும். 24, 38, 34 வந்து
38 தான் கம்மியா இருக்கு.
அதிகமா இருக்கிறது வந்து 34 தான். 34 சொல்லியிருக்காங்க.
34
Okay, so I think I will discuss about this one because only 57% of them have got it right. The correct answer is 34, and the reason why I asked this question is because sometimes we need to know the distance between the micro etchings. It is a standard one. It is 34 mm. The reason that we need to know that is because sometimes you may find when you want to remark the lenses, one of the etchings may be missed sometimes. So if you know that the distance is 34 mm, then it is easy for you to use the layout chart and remark the lens. So that's one of the reasons why it is important for us to know the distance between the micro etchings, and irrespective of any of the progressive lenses, the distance is only 34. It can't change. Okay, so before we move on, let's try to understand the reasons for non-adaptation. Some of them, they may not get used to the lenses, whatever measurements we take, whatever refraction we do. It could be due to errors in refraction or dispensing. There is one category which I have not mentioned, which means there is a third category, apart from whether, even if you have done a very good refraction, and even if you have taken very good measurements, dispensing measurements, there are very small percentage of people who may not be happy with the glasses prescribed. So, I'm not going to discuss about that category, but I thought I will just mention that here. That means a small percentage of people may not get adapted to the progressive addition lenses at all. So keep that in mind. Okay, we actually wanted to understand some of the reasons for spectacle reassessment. So this is taken from our hospital data, and what we found was majority of the reasons for spectacle reassessment in our data is because of refraction, the first one, about 54%, and the second reason was dispensing error, 21%. The other reasons were documentation errors. What I mean by that is when optometrists document the refraction, then they document it wrongly. And transcription errors. Transcription errors are when the prescription are issued and when the opticians, when they enter the values, then they make some mistakes. Those are transcription errors, and there is a small percentage of error. It could be because of pathology, so which we are not going to deal here. I am going to cover in this session mostly about the dispensing errors, and maybe in between I'll give some refraction tips as well. Okay, so what are the sources of errors? Actually, when we look at the sources, majority of it could be because of one, the frame alignment. So when we deliver the progressive addition lenses, we need to make sure that the frame is aligned well on the face. Because why I say is because when we dispense, we think that the frame is aligned properly, but most of the time when we put it on the patient's face, it may not be sitting properly. So I think this is very, very crucial. And because all the faces need not be symmetrical. Sometimes there could be some asymmetry because of which the frames need not sit properly on the face. That's one. The second reason could be, there could be some errors when we fix the lenses. Either the dispenser may be taller than the patient or vice versa, because of which there could be some errors. Or while fixing, there could be some errors. That is one. Similarly, there could be errors in the horizontal centration in the form of IPDs. And while fixing the lenses, there could be some changes in aligning the lenses horizontally. So the micro etchings could be tilted also. And so that's why I think Ajay also touched upon the importance of on-eye assessment. That means when you're delivering the progressive addition lenses, it is important for us to check for the frame fit so that the alignment is fine. And also we need to make sure that the fitting cross is sitting right in front of the eye. That is one. And with all this, you check for the distance and the near vision. Okay, so in spite of that, you have taken utmost care in doing all this. In spite of that, a small percentage of people may be unhappy with the glasses. So what do you do? So when they come to you, see, none of us like to see the patient for the second time, after a week or 10 days later. But believe me, there is a small percentage of people who would want to see you because they have some difficulty. So how do you tackle this? I always say this: don't assume. That means sometimes we may tend to assume that they are malingering, they are able to see, but they are jobless kind of thing. We tend to think about it. So don't always assume things. I always observe when they come to us. You observe very closely, and then when you observe, make them sit, and then when you talk to them, you will be able to identify what is going on. When you observe their visual behavior, you should be able to find out, or you will get some clues about what he or she is going through. So you empathize, and good communication is the key, which means that you show the intent that you are trying to help, you are trying to understand what he or she is going through, and then slowly they will open up. So, and sometimes you have to make them understand, make them realize that what is the real expectation, which means that sometimes their vision could be 618 or 612, but they would their expectation is something very different. They want their vision to be very good. So you need to spend some time to explain to them and make them understand. So this is how you need to do it. So the moment they come with a complaint, so you try to identify the dispensing part of it, which means that you check the measurements on the lens, and if all the measurements are fine, you check their vision. And if you find that some of the measurements are not correct, for example, if you feel that the fitting height is, say, for example, 2 mm lower than what is needed, you try to adjust, and then you try and then check their vision, make them sit comfortable, and then make them read to see whether they are fine. And if they are fine, then maybe you follow them up closely, and then you make sure that they are comfortable. Suppose if you are not able to adjust, even after adjusting, if they say that they are uncomfortable, they are not comfortable, then the only option is to remake the lenses. But you try and make this effort, is what I'm saying. Suppose you've done all this, you feel that still he or she has got some difficulty. Then you try to check the refraction. Then you check the vision with the current one. If they are not able to read with the glasses, then you know that something is wrong. So you go for, you check the refraction, and if there is any change, there is no way that you could change that in the existing one. We have to go for a new lens to remake the lenses and follow up. Suppose if they are able to read with minimal changes, and then you try to adjust or talk to them, and if they are able to adjust, then it is fine. So before we move on, Paula, can we go for the third question, please?
Sure, sir. sharing the results.
Thank you. Thank you. I think majority of them have answered it rightly, so I'm not going to discuss. So before we move on to the troubleshooting cases, I thought I'll just discuss about some special case dispensing. Sometimes we may get to see pre-presbyo who is not yet presbyo, but he may have some fatigues at near, he may have some difficulties or discomfort at near. So if you carefully look at their refraction, he may have some latent hyperopic component. And if you really probe into his complaints further and try and check, and if you don't find any other thing except for the latent hyperopic component, it is usually recommended to correct the latent hyperopic component, and he or she is going to be fine at least for some time. So which will take care of his complaints as well, both for distance and near. So this is one situation. The second one is very tricky in the sense that sometimes they may not reveal any other detail except that they may come and say that I just can't see things clearly. But if you try to probe further, then it could be like sometimes, they may have some ergonomical issues, like he or she may be taller than the computer or the desk. So he may have to bend down, or he may be taller and the desk may be shorter, or there could be some powerful light from the window which would fall on the monitor. So these are some of the ergonomical things. Only when you probe and then try to understand, you could probably give some sort of solution, one. Or there could be other times where we may have to consider prescribing some additional prescription for that distance as well. So we may have to adjust or tweak the prescription for that distance. So this is another situation. And the third one could be like when you perform PV assessment, and you may find that some people may have some phoria or a disrupted binocular fusion, where they may require some sort of prisms into their prescription to alleviate their symptoms. So in such cases, especially when you find the prism power to be equal for distance and near, then you could possibly dispense the prisms in a single progressive lenses, which means both for distance and near. But at times when you find the prisms to be very different, for example, different for different distances, one for distance and the different prism for near, then it is not possible at this point to incorporate the prisms in a single progressive lens. So you need to either consider giving him two pairs of lenses, one for distance and one for near usually. This is another situation. And like phoria, there could be tropic conditions, sometimes associated with amblyopia and or suppression as well. In such situations, sometimes it is very tricky to take measurements. So you could possibly cover either of the eyes and then take the measurements. That is one. And the dilemma here is whether to consider progressive lens in the eye which is amblyopic. So usually what we recommend is we generally recommend progressive lenses for both right as well as left, because the patient should have equal peripheral perception. So it is important for us to give progressive lenses for that eye as well. There are some situations like high ametropic prescriptions where myopia could be over 6 diopters or hypermetropia over 4 diopters with cylindrical error about 2. The challenge here is because of the magnification and prismatic effect, there could be, from distance near when they are viewing, there may be challenges and discomfort as well. So what we generally, if they are, habitual user, then sometimes they get used to it. But sometimes what we also recommend is shorter corridor progression for myopes for the simple reason because because of the base down, the image is up. So for that reason, we recommend for shorter corridor progressive for such high hemetropic myopic prescription. And the opposite is true in case of hyperopes, which means the hyperopes would be able to adjust it in a better way if it is, even though if it is a high hemetropic prescription, they would be able to tolerate it in a better way compared to myopes. There is another situation where when we prescribe hyperopes, especially when we are ordering for the second pair or from the previous pair, when there is going to be a change in base curve or the index, then sometimes hyperopes are very, very sensitive to these changes. So it is important when we order for these, especially these higher powered for hyperopes, it is important to check for the base curve using Geneva lens measure. So this is something we need to keep in mind. Okay, so let's move on to the real-time cases. So the first case is a 46-year-old female who's a software engineer who's been using glasses for distance alone. And when she came to us, she was complaining that she had to remove her lenses to do her computer work, which means she had to move closer to do her computer work. So we prescribed her, an addition power of plus 1.25, with which she was comfortable. And we took all the other measurements, IPD, fitting height. And then with the new glasses, when she came to us, she had a difficulty of, she was complaining that her reading area was too small compared to the previous one. And also she had to push the reading material to one side for her to look things clearly. So these were her main complaints. So we measured all the measurements on the lenses, and when we measured on the left lens, we found that the lens, instead of 34 mm, it had only 30 mm, and instead of 24 mm, it had only 21 mm. So there is a change in IPD of 4 mm on the left side and a height of 3 mm. Usually what we encounter is whenever there is a change in fitting height, for example, say 1 or 2 mm, then it is possible for us to adjust the frame a bit and then give them some time to get used to it. Usually they get used to it. But whenever there is a change in the IPD, like in this case, say from 34 mm to 30 mm, this we can't adjust for sure. So the only option for us here is to remake the lenses. So the point here is, if you either make any error horizontally, say IPD errors, or vertically, it is very difficult for us to adjust. One. The second thing is, what we have to keep in mind is always, that is the reason why we tell people to, you adjust the frame, whatever you want to do, you adjust. After adjusting, then you take the measurements. This is one of the reasons why we tell to do all and then take the measurements. Because after that, once the lenses are made, you can't meddle with the frame too much. That means you can't adjust too much. It will not look good on the face also. So that's the point. But honestly, if I want to confess here, that these kind of errors we are not seeing much nowadays, at least here. That means, we have really improved in this area because of various gadgets. Most of us are using pupillometers for measuring IPD, using edging machines to fix these lenses. But in spite of that, there are errors, but I'm saying that it has come down drastically. So that way, we are happy about it. But this could be one situation that we could face. The next is anisometropic prescriptions. These are sometimes, this could be very tricky because of the difference in power between eyes, more than one diopter. There could be differences in prismatic effect from distance to near between eyes also. And because of the difference in magnification, there could be difference in retinal image size as well. So it is called as anisoconia. So let's look at this case number 2. This 54-year-old male who came to us with actually plus 1.5 and plus 1. And when we did the refraction, we changed it to plus 2.5, plus 1.5 with the same addition. And when we measured all the measurements which are mentioned here, 32 and 31, and the other measurements were fine. But when he came to us, he had difficulty, especially for near more than distance. So what we found was when he was viewing from distance to near, look at this, from the right and left, what we could see is the right eye, the prismatic effect was 3.75 base of prism, and the left eye 2.25. There was a difference of about 1.5 prism base up. So this particular patient, see, usually people will be able to tolerate one prism, up to one prism to some extent. There could be cases where even if there is a 0.25 difference also, there may be cases where people are very sensitive. But usually one prism is what people will be able to tolerate. But in this case, because of that, this particular patient had difficulty. So the options are like this. So you could probably suggest a short corridor progressive lens where he may not have to look at from distance to near if it's going to be a long corridor. So if it's a short corridor, the idea is to minimize the prismatic effect. Or in case if he's still not happy with it, probably for one particular distance, if he's very particular, we could also consider a separate prescription for that distance. Or occasionally, if he is fine, then we could give him a contact lens for the left eye and then match the one on the power to the right eye like this. So you could consider giving him contact lens of +1. And so you could match the right and left eye distance prescription of +1.5. This is just for the sake of completion, I'm saying. So anisometropia is not a contraindication for progressive lenses. It just requires a specific attention is what I want to emphasize here. So the first case had differences in the fitting height and the IPD. The second one is more of a difference in power between eyes. So we may have to do some adjustments and then try and fix it. So it's a different one. Third one is very similar, but we face it very frequently in our tertiary eye care center, where patient get operated, in one eye. For example, this case is a 53-year-old female who uses computers a lot and who came with -3 and -2 in the right and left with +2.5 addition. Now she got operated on the right side for cataract on the right eye. So the issue when we prescribed -0.5 and -2.25, a difference of 1.75, isn't it? So with this, she was not comfortable mainly for near. So often she had to remove her glasses to read, and she was also finding it difficult to drive and do other activities. So this is a very, very tricky situation. because sometimes they may have to wait till the other eye gets operated. So in the temporary interim period, what do you do? The tricky one. So you could, based on the situation, you could possibly suggest a separate prescription, consider a different prescription for that particular distance apart from the progressive lenses. That is one. Or like in the previous case, you could also combine one contact lenses and progressive lenses, or consider a different one for intermediate and near. So that is again one of the options. So these are some of the options which you will have to decide based on the situation. So this is another situation. The fourth case is a very different one. There was patients with monophthalmia where the patients are born with only one eye. The other eye is non-functional. So sometimes, or not sometimes, most of the time it is congenital in nature. That means it's long-standing. They may not have adequate convergence because only one eye is functional. If it is acquired, probably they may have some convergence left. So we'll see a case here. Here is a 53-year-old male who came to us who had +3 in the left eye with -1 cylinder, had good vision in that in the left eye, no PL in the right eye. So when we gave this, he had some difficulty, especially for intermediate and near. He was not comfortable, but he was comfortable for distance. So when we probed further, when we asked him what exactly is his problem, he was in fact complaining that he was not able to see how many zeros, or not able to appreciate or count how many zeros. Instead of 4, he was counting 5, something like that. So he was very uncomfortable doing some reading, especially continuous words or numbers. So when we looked at his measurements were fine. It was 34 mm on the left side and with a fitting height of 21. And he was fine, actually. What we observed was we failed to measure, or we failed to understand his convergence, which means the distance IPD is measured but not the near one. So unless you measure the distance and the near IPD, you will not be able to understand the divergence. So that's the message here. So if you know that the distance is not 2 or 2.5 mm, then you know that the regular insert is not going to work for that particular individual. So whenever you try to take measurements, it is always important to measure the distance IPD and the near IPD to understand the divergence as well. And if there is any change that you need to do, you need to inform the manufacturer to alter the insert. This is one very important thing. Need not be only for monophthalmic prescriptions. It could be for even other prescriptions. So the take home is, when you do the measurements, though you may use only the distance IPD to fix the lens, that's fine. But it is important to measure the distance and the near IPD for you to understand the divergence part of it. So this is another important information that I would like to share here. The fifth is purely ergonomic case where 56-year-old male who is a movie editor, and when he came to us, he was wearing -6 and -6.5 with 2 addition. And when he came to us, we changed his prescription a bit. With +2 addition he was using, and he was given +2.5, and the left eye power changed from -6.5 to -7.25. So with the new correction, he had neck pain. He was not comfortable for his near as well as intermediate distance. He had all sort of complaints with the glasses. So when we probed further, he was not able to read. So he was feeling that his power was too strong for near one. And because the screens are located at least 80 centimeter high, also it is about 50, 60 centimeters away. The screen was away. So because of which he was finding it difficult with the regular progressives. So what we had to do was to understand his distance, understand his work, where he was working the intermediate one. So we had to tweak the prescription for intermediate to -5 and -6.25, and for reading -3.75 and -4.75. So the message here is sometimes one progressive may not be good for all the situations. So we may think that it has power for distance, intermediate, and near, but it may not be satisfying his need because of the because of his occupational need, like in this case. So we may have to consider additional one in the form of either occupational progressives or a separate prescription for that particular distance. So this is very, very important. Sometimes progressive may not work for all the distances. So just to summarize, so when somebody is unhappy with his or her glasses, it is important for us to distinguish between either a dispensing error or a refraction error. If it is a dispensing error, it is important for us to find out what is the dispensing error and try and adjust, if not remake. And in case if everything is fine and if it is because of the refraction, we have to go for a re-refraction, and if the values are different, then definitely we have to remake the lenses. And what is important is most of the time, one progressive should be fine, but there are situations where we may have to consider additional lenses or additional prescriptions or additional occupational progressives for other distances as well. So thank you so much. Let's stop sharing.
Thank you so much, Vishwa sir, for this wonderful presentation. I really personally like the flow chart of a systemic approach to troubleshooting progressive addition lens wearers. And I also like the fact that you stressed that in certain situations, more than one pair of progressive lenses will work for patients. So you shouldn't have a very rigid approach to, dispensing progressive. You should have a wider scope of practice, and being practitioners and dispensers, we should not restrict ourselves and, expect too much out of just one pair of progressive lenses. Of course, there is a disparity between expectation and reality for the wearer as well. When we give in too much and talk too much about the advantages, we are giving them more, we're making them expect too much out of a single pair. So at times they feel cheated and they just not convinced that with one particular pair, and they were never happy, and they keep coming back to you, though there may be no actual issues to the existing pair. So thank you very much once again, Vishwa sir. So before we move on to the panel discussion, I have a small announcement to make. We will be sharing a survey link, which will have a couple of questions, which will be shared towards the end of this webinar. This will be shared in the chat box for Zoom audience, as well as for our live audience on Facebook as well. So please do take time out to answer the survey. Thank you very much. So a couple of questions have come up in the chat box. I will be taking up one at a time. And also the case discussions which you explained, Vishwanathan sir, was excellent. I mean, it covered every aspect, every possible areas have been covered. Nevertheless, if you have any questions from the audience, we are more than happy to take it up for discussion. So moving over for the panel discussion, I have a question. So more often when we talk about, troubleshooting, you've covered refraction errors or dispensing errors. How often do you come across problems or troubleshooting in your practice where a problem arises because of disparity between a frame design and the progressive addition lens design? Reiki sir, you may also pitch in with your experience. So I'm opening up this discussion.
Yeah, I think I did not cover about the frame selection deliberately, Anita, because I think Ajay did mention about it. So yeah, because you're asking, I'll just tell. Because sometimes it is also possible that if we select a wrong frame, then that may give rise to some discomfort as well, because there are certain frames which may not be suitable. And if we really understand, in theoretically, sometimes, they may say aviator may not work. And if you actually look at the logic, any frame when you select, it is easy for us to just put it on the layout chart to understand whether the lens, both the distance and the near, is coming into the viewing area, is what I would suggest, irrespective of the frame shape and size. Because sometimes what happens when we say that aviator may not work, some people are, very particular that I want to wear progressive lenses in this frame only. You are making me to buy a new frame, they would argue. So the best thing would be to put it on the layout chart, which doesn't cost you much. It's not going to take more time as well. So put it on the layout chart to understand where exactly is the distance one, near one. If you really look at it, then you will know whether he or she is going to be happy. So I would say that frame selection is important. And once you are convinced, you check it on the layout chart and then decide, is what I would say.
Thank you, Vishwa sir. Rekhi, your take on that?
Yeah, Anita, I just wanted to clarify, when you said design of the frame versus design of the lens, are you referring to the base curve or are you referring to the shape of the frame?
You could cover both. I mean, base curve is a different aspect also that
because I was wondering on the design. Yeah, so the basic thing that I would say is that as a practitioner, you should first decide on what lens is suitable for the person's profession and his prescription. Based on that, you should select a frame. Unfortunately, far too many of us select a frame first and then decide what lens to fit into it. So if you have clearly demarcated the kind of lens that you're going to use, then when the patient is trying to select a frame, if he chooses to, it's easier for us to guide him towards a frame that is more suitable for him. So for example, if a person has a very high power, it could be both plus or minus, his PD is small, but his face is large. So you end up in a situation where either the lenses will become extremely thick or ungainly, or you need to select a frame with a high sort of an inset in where the lenses are compressed around the face, around the eyes. That's one way to work around it. There are certain people who like to, wear, like Vishwa was mentioning, wear sunglasses or, if you've got a -7 and you want to wear an aviator frame in a progressive, it becomes a little bit difficult. So there are aviator designs available, which will actually have a little bit of a cut here and make it smaller. Base curves start playing a role. If you have high minus powers and a highly curved frame, then you end up with extremely thick lenses or extremely expensive lenses. So I think that's where, when it comes to these prescriptions, as a practitioner, you have to guide the patient towards the right selection of frame and give him the choice of selecting a frame which makes the lenses more cost effective and thinner. Alternatively, if he just decide to go for a really wide frame and high base curves, and he's got a -3 and he wants the lenses thinner, then it's a gold mine for you in terms of giving him an extremely expensive product. But these are the possibilities. I think your job is to really list out the possibilities and what are good for the patient, and then work around from the vision aspect to the cosmetic aspect. If he decides to go for a cosmetic frame, then tell him, okay, for cosmesis, this is what's going to work.
Thanks, Rekhi. So taking up from where you left with regards base curve, is it only the high ametropic patients who are pretty sensitive towards change in base curves, or just about anybody could be sensitive towards this change?
No, I think base curve changes are quite, it is a sensitive thing. You cannot afford to have multiple changes in base curves from one prescription to another, because it does make a difference to the magnification of objects and it does affect the person's vision. So selection of a frame, I've always found that when you start a person on a progressive journey, it's good to keep them on a similar type of lens and predict the kind of changes that you are expecting, and guide him towards a lens which is going to be used in the future, and get him used to those lenses from the time on that you start him off on. I think Vishwa might have some better input on this.
No, I agree completely, Rekhi. The point that I wanted to make here is, sometimes when the patients order 2 pairs of lenses, and if we make different lenses with different base curve, they may have some difficulty, or they will be able to appreciate it immediately. So we have had such experiences as well. So they are happy with 1 pair, and immediately when they order, the lab may not have the right base curve. So they may opt for a different base curve, and because of which, the patient may not be happy. So this has happened to us, and so I wanted to share that actually.
Thank you so much, Vishwa and Rekhi. I have a question for Reshma, because you are in the industry and you are in the market as well. Like, how often do you have troubleshooting cases where someone has dispensed a brand B over a brand A? Supposing a patient is used to wearing brand A, and then now the dispenser has convinced him for brand B. So this change in brand, does it affect the wearer, and there could be some troubleshooting happening because of change in brand?
Hello everyone. So basically, whenever we are changing a brand, in that case, what is very important is that in the previous brand, so like we in Progressive, we have various range, like from budget range to mid range to customized range and all. So in a previous brand, whichever he was wearing, so in what level he was wearing. So we know what kind of expectation he's having, what kind of field of view he's already experiencing. So that is more important. Each brand has certain mid-range in wherein there are various technology used in terms of controlling the distortion. The name might differ from brand to brand, but then we have various segregation. So based on that, that is important. What I have noticed, like somebody who's already wearing a customized range, for example, and he's from X brand, and then they end up going a mid-range or a budget range. So in that case, the expectation is not matched, although they changed the brand, but they didn't see what he was wearing earlier. So in those cases, the troubleshoot, what we have seen, like in habitual prescription, habitual design, what they are used. So apart from that, I don't see any thing shifting a brand, because most of the see premium mid-range, the technologically all free-form lenses are made depending on what kind of parameters they take into consideration while making the lenses. Like, yeah. Also,
Anita, can
more
I
than
ask?
design, yeah.
Sorry, Reshma, go on.
No, yeah, just more than a frame lens. The frame also matters. Like which kind of frame he was wearing earlier. So that also sometimes lead to the difficulty in adapting to the new lenses. Usually. Yeah, ma'am, you can continue with your question.
Can I ask the question, Anita?
Yeah, sure.
So this to all 3 of them, Rekhi, Vishwanath, and Reshma, just your thoughts. Let's say somebody who's had a very bad experience with Progressive earlier, the first generation ones when they used to come with hard design, and they didn't adapt to it and all of that. And then they've come to you, or for whatever reason, they did not adapt earlier. And you're trying to say, okay, Progressive would work well for your occupation. And so how difficult it is to convince the person. And, when they're already there with that negative mindset, right? That I've had this experience, it doesn't work. So how do you approach these kind of people? I'm not saying that it's going to work 100% again. I'm just saying, how do you, for all the prescription is very simple. So they can get adapted to Progressive lenses. So how do you approach these kind of people who already come in with a negative mindset?
Yeah, I think it's a good question. Most of the time when we talk to them, when we make them understand about Progressive lenses, and if they have had some bad experiences, then they are a little hesitant to go for it straight away. We may have to explain about. Fortunately, we have many options. I should say many good options now. There are definitely very good lenses available today with distance, wide, intermediate, wide, near. So usually they are, when they are complaining, they are, most of the time they are very unhappy with the intermediate and the near. Okay. So when they are very unhappy about this, we can talk about the options available. And usually, when we talk about these options, they are ready to, try out one of these advanced designs. But there is a category, where if patients have had bad experiences with reading glasses or sometimes with, one type of lenses, it is very difficult to convert them. That's what I've seen over a period of time. For one distance, if they have used, it's very difficult for them to use a progressive, be it any advanced design. Sometimes very difficult to convert.
So basically,
otherwise,
you're saying activity dependent, one particular activity dependent.
Yeah.
Reiki?
So, as I understand your question, you were saying that a person has had a bad experience with progressives many years ago. So how happy is he currently? If he is sort of adapted to wearing maybe multiple sets of bifocals, a distance near prescription and a bifocal, and intermediate near and a bifocal. If he is happy and reasonably well adapted, I think it's better to perhaps leave him alone. However, I think a multifocal makes a suggestion of a multifocal is, or for that matter, a suggestion of any type of lens is usually to solve a problem for a patient. So if a patient is having a problem where you feel that a progressive is definitely going to help him and has to have a high probability of helping him, you can say that you can wear this progressive for this particular activity where you will not have to change glasses multiple times. For example, if he's wearing 2 pairs of glasses and he goes to a meeting where he has to see his computer, he has to read and look at a presentation, he obviously can't wear 2 bifocals. So in those sort of activities, you can suggest that we'll give you a multifocal. The other advantage that is there today is one, as Vishwa touched upon it, is that you've got fantastic designs available. The other advantage you have is that you have a good relationship with your lens manufacturer. Today, I have the freedom to give a lens free of cost to a patient and say, well, if you adapt to it, you pay for it. If you don't, give it back to us. And, at least you made the attempt to try and make the person comfortable. So conversion is extremely difficult when a person has had a bad experience. But I think the choices that you give to the patient then becomes critical. And I found that when you get a person happy in a situation like that, he's a repeat customer, and he's a person who actually refers a lot more to you, saying that you solved a problem that others couldn't. So I think it's a great opportunity.
Yeah, I think that was a very good point you touched upon, saying that you attend to the needs of the patient. Basically, what does he come for? What's the need? And how can you solve that need by prescribing a multifocal lens? So, Reshma?
Reiki sir has already mentioned why that dropout, like what was the reason for him, what issues he was facing with the old progressive. Of course, with the newer advanced design, most of the complaints, also at what level he's starting, like, addition is what, like the progressive, the earlier he starts is okay, but as the addition goes higher and higher, it's very difficult to get adapted to the design, addition of what we have noticed, like 2.25 and above, they start late, start the progressive way. So the adaptation is little difficult. So of course, the expectation, what does he want in the new design and all, if we are able to match it, then of course we can recommend them. Also, it comes with adaptation warranty, so might as well try it for him.
Thanks, Reshma. So Vishwa sir, you had one case on differential prismatic effect at NIA. So we have a question from the audience. So can prism thinning be done to counter the difference in prismatic difference for NIA?
So prism thinning is for a different concept and nothing to do with the prism prescription. Prism thinning is there in all the progressives. So prism thinning is basically because when you give power progression from distance to near, if you don't give prisms, the lenses will break towards the end. So for that reason, to support the lens, you give the prism thinning. So that'll be there in every progressive lens. This is a different situation where they may have to prescribe prisms to alleviate his symptoms because of his binocular vision issues. So what I spoke is because of that and nothing to do with prism thinning.
Thanks for clarifying that, Dr. Vishwa. So we have this question, I guess you have addressed this. Nevertheless, I'm just taking up this question. So wherein one eye is pseudophakic, has an addition of plus 2.5 and the other eye has no addition. So how will you advise this patient towards taking up progressive lenses?
There may be some situations, not very common, but yes, possible. For example, patient have had some accident and he may have to undergo surgery because of that traumatic cataract. So in such situation, we may have to give, in normal circumstances, we wouldn't suggest that. But in this situation, there is no other choice. We may have to go for it. But usually if you give them these lenses, if they are young, they get used to it. That's what we have seen. Sometimes if they are not, then we may have to opt for other management, like what I said. We may have to consider giving him lenses for that particular distance, or combination with contact lenses and things like that. But generally what I have seen is they get used to it. Yes, the answer to your question is yes, possible.
Thank you, Vishwas sir. I guess, do we have any questions from the Facebook Live audience, Lakshmi or Paula?
No, nothing, Anita, but a lot of appreciation for the different cases that Vishwa presented. I think you really covered a lot of aspects, Dr. Vishwanath. So a lot of appreciation coming from that side.
Yeah, thanks, Lakshmi, for briefing us on that. And I guess with this, we come to the end of today's webinar, as well as the Shri Rajni Turakhia Memorial Optometry Lecture Series. We've conducted 4 webinars. With this, I would thank everyone for having joined us, especially those who have followed us in this lecture series and benefited a lot from the very important lectures that have been covered by our eminent speakers. I would now like to invite Mr. Sanjay Tiwari from Hoya to speak a few words before we conclude today's session. Over to you, Mr. Sanjay.
Before you start, Sanjay,
to everyone.
Before you start, a big thank you to all the support that you and Reshma have given throughout this program. Thanks a ton.
Thank you so much, Lakshmi and Osei, all the team. Just tell me how much time do I have, because I know we are touching almost 1 hour. So, I can go on and go on. So if you have to put it, you have to tell me, okay, you have so much time to talk, so that I'll plan accordingly to speak, No,
we leave it to you. You can decide.
Okay, I'll be brief, I know, with this. So I think first I would want to thank OCI and Lakshmi and Anita and all the members of the OCI for putting this all together. It has a wonderful, the series of 4 lectures, and I think extremely well managed and a great response, which I think everyone is seeing that the responses have been excellent. I think I will say much better than what was expected, number 1. And number 2 is that I think I also want to thank Snehal and the Turakhia family for agreeing to our request, because we wanted to put this in the memory of Rajni uncle, and it was something which we went to Snehal and everyone. I think they agreed to this, because this is a small way in which we want to respect Rajni uncle. So I think we are very grateful to entire Turakhia family for accepting the request and allowing us to put this series of lectures and dedicating this to Rajni uncle. And number 3, I think one thing very, very important, I think I would want to remember Rajni uncle, because he was a legend, and I know he will always continue to live in our life, in our hearts. And what his teachings, even Yash shared, I think they were very, very practical, and it will continue to guide us forever. And in the positive, because we have a lot of paucity of time, so I will not get into all the names, but I think all the speakers we have chosen for this, for this series of lectures, I think they're all very gifted, very eminent personalities, and they have gone into detail. And I think one thing I would want to congratulate everyone is that unlike most of the series of lectures, what is more theoretical, more of a bookish. I think what was very different in this lecture series was everything was practical and coming from people who have a lot of experience behind them. Otherwise, you can't have these kind of case studies, It comes after decades of experience of helping the customer. So I think this is how the lecture series was different than all other things I've seen so far. Practical tips, I'll say wisdoms from the eminent and gifted people who have been handling the patients for years. Extremely, extremely knowledgeable. But I will also want to say something. Mostly what happens, we listen to lectures and forget. And I know any knowledge which is not put to practice is waste of time. It's a disrespect to the teacher and wastage of time for everyone. See, ultimately, anything which you learn, if you don't put into practice and for the benefit of a patient, it is not worth it, you know. There are so many 4 lecture series coming from Ajay Bhai, talking about Dr. Vishwa, Ricky sir, you know, everyone, you know, it was so many excellent and the practical tips. Even if you can put even half of this into the practice every day, I think our entire optometry and the eye care will go to a different level altogether. Also, Hoya is very happy to be part of such initiatives because Hoya always has been supporting these sort of initiatives and will always be willing to support such initiatives. And once again, thank you so much to the OCI, all the speakers, all the participants, and also wanted to say a couple of things about Hoya. I think it will not be right for me to conclude without talking something about Hoya. Number one, very briefly, I'll say, we always have a stated mission where we say we are here to evolve a win-win partnership between the ECP and the company. Number two, we see all the challenges, all the opportunities from your eyes. So we work together to find a solution which will delight your patients and your customers. And last but not the least, always you will find Hoya supporting eye care, its needs for the future initiatives, and also will stand with all the ECPs. And thank you so much on behalf of Hoya, and great job. We are so happy and look forward to taking this initiative forward. Thank you so much.
Thank you so much, Sanjay sir, for your kind words of appreciation. And thanks to Hoya as well for partnering for this lecture series and brought about a lot of change in the thinking in which we will go about dispensing progressive lenses. At least that was the theme of the lecture series. Thanks again to Dr. Vishwanathan, Mr. Rekhi, as well as Reshma for joining us, taking their precious time out and enlightening us with their experience in the progressive lenses. So thank you all once again from our team here.
Thank you. Thank you once again. Thank you so much.
Thank you. Thank you, Anita. And thanks to Paula, who's always been behind the scenes and helping us, two great women who've really put this entire show together. So all credit to both of you, Anita and Paula, to making all the 4 lectures such a, valuable educational series. Thank you. And thanks to Reshma. Thank you so much.
Thank you, Paula. Thank you.
Reshma has always been there in each of these, and thanks for your contribution also, Reshma.
Thank you.
Thank you. Pleasure. Pleasure. Thank you so much.
Thank you.